Hello everyone, hello and welcome to aidsmapLIVE HIV Prevention Special. I'm thrilled to be joined by an absolutely phenomenal panel to discuss all things HIV prevention, including oral PrEP, injectable PrEP, PEP, treatment as prevention, and the role that people with HIV actually play in HIV prevention. But first of all, let's meet our glorious panel. I have to say that we're meant to have Sophie Strachan from the Sophia Forum with us today, but unfortunately, she's not very well. Get well soon, Sophie. We'll be thinking of you. So first of all, Gus Cairns. Gus has been an HIV activist, oh my goodness, for decades. Has been living with HIV since 1985. Was the former editor of Positive Nation magazine that gave me my first opportunity for writing. Been a writer for aidsmap for ages and has recently retired. But you're going to be continuing writing for us, as well as doing other things. And Gus, you've just come from abroad. Where have you been?
I've been to a European Community Advisory Board meeting in Frankfurt. So all the post-COVID meetings that used to happen on Zoom are now starting to happen in person.
Oh my goodness, yes. Thank you very much for joining us, Gus. Next we have Chamut Kifetew, who works for Terrence Higgins Trust, managing the National HIV Prevention Programme for England. Welcome, Chamut, or Cham?
Yeah, you can call me Cham.
Cham. So Cham, talking about being back in person, how are you finding moving from being on Zoom all the time to actually doing things like this in person?
I mean, I have to say it's a really nice change. I think it's been good. It's expanded what we can do to be online, but nothing beats having a conversation face to face and that sort of organic, idea generation. And so I'm really enjoying the back to face to face.
Wonderful, thank you very much. And then next to me we have Professor Marta Boffito, who has the coolest glasses in the world. I've got
They're
to
real,
say.
by the way.
They are real, yes. Marta is a consultant physician at Chelsea and Westminster Hospital and Imperial College London, and the lead of the clinical research faculty on HIV service, and the HIV service director at Chelsea and Westminster Hospital. So I will, don't put your glasses down because I might have to take those. They're very cool. Next we have Jason Domino, a sex worker and leading sexual health activist. He's also the online rep at United Sex Workers Trade Union and founder of Porn for PrEP. Now, Jason, I think that you have shown your commitment to PrEP more than anyone else. How have you done that?
So, because I'm also a porn actor as well as a general sex worker and activist, I thought it was important for me to have a tattoo.
Yay!
So that when I'm not wearing as many clothes, then people still know what I stand for and start conversations that way.
That's very good. So I think later, I think we're all going to head down to the tattoo
I think we're going to have to.
together. And finally, we have Winnie Ssanyu Sseruma, an international development consultant with the bulk of her work involving assessing community health projects for the Stephen Lewis Foundation in 20 African countries. And Winnie has recently started an initiative called the Black Health Activist Mentoring and Empowering Network. Thank you, Winnie. But Winnie, you're also writing a book that's going to be out soon.
Well, I'm writing a book with 4 of my other friends, and it's about celebrating the strength and the resilience of African communities in the UK for the last 40 years, and the contributions that we've made to make sure that our communities are aware of HIV and to reduce HIV infection. So it will be out in March, April 2023.
Wonderful.
So look out for that.
Yeah, look out for that.
Thank you, Susan.
So for people who are watching, do please get your questions over on Facebook and Twitter, and I will try to get some of those questions over to the panel. But if we can start with you, Gus. When I started working in HIV, actually writing for Positive Nation many years ago, I remember one of the main discussions around HIV prevention was about ABC, abstinence, be faithful, and condomize, which seems quite archaic now. But how far have we moved on in HIV prevention over the years?
It's a completely different world. I mean, it worked to a certain extent. The encouragement of people to adopt behaviours that get them less at risk of HIV, you know, certainly in a number of places condom use shot up enormously, STDs went down, and HIV sort of stayed about level for a long time. But I had a feeling that it would take something stronger, and I had a feeling that the drugs might be involved from quite an early time. I knew very early on, because I read studies, that because I was virally undetectable, I was very unlikely to be infectious with HIV. And in about 2002, I started hearing about this new idea, PrEP, about giving the HIV drugs to negative people to stop them being able to catch it. And I followed that trail of research from then on and got involved in quite a few of the studies, including the PROUD study. And from about 2015 onwards, I think we knew that HIV prevention was going to start working much more seriously than it had done before, because of the contribution of antiretroviral therapy to it.
Yeah, wonderful. And I'd like to ask you all, what do you think is the biggest game changer in HIV prevention? If we start with you.
Wow, right off the bat. I think it's hard to say there's one specific thing, but in my view, I think giving people choice in options, whether that's for all the prevention options they can take up, whether that's PrEP. And I mean, I know condoms aren't everybody's choice. They're fewer people's choice than probably a lot of people would like to think, but giving them the choice to take up what they want, even with treatment, having different treatment options to maximize adherence. And also looking from an equity perspective, looking at those people who haven't been able to, or who have not been reached, giving them more choice puts them in a better position to take up the prevention, to take up testing and everything that they need for us to, stop new transmissions.
Yeah, absolutely. And hopefully we will be discussing some of those issues today. But for the rest of you, if you had to pick one thing in terms of HIV prevention, what's been the biggest game changer for you?
Well, if infectious diseases are preventable, the majority of infectious diseases are associated to vaccinations or other prevention tools. So growing up, within the HIV community, because I started to work in HIV very, very early on in medical school, even before I was a doctor. Being actually able to say it's another infectious disease that actually can be prevented has been incredible. And also, it's another kind of level of HIV that started as a quite serious disease, clinically speaking. Not that it's not serious nowadays, but it was quite scary before antiretroviral became available. So it is actually something that can be prevented. Okay, there's no vaccine, but there is PrEP. It makes the whole story a bit more positive, and it's incredible that people can just take PrEP and not get HIV nowadays.
Absolutely.
And just to add to this, it was the activism of people like us that knew that taking a pill would prevent it, because I remember those conversations much earlier than I practiced. I'm not doing any names like you, but people knew. And what I think it needs to be said is that in HIV, the activism, the collaboration between the scientific community and everybody else and people living with HIV has been incredible, because it's someone actually going to the scientist and say, you need to do this study, this works, and it's incredible.
Yeah, absolutely. Jason?
So for me, I'm quite a big proponent for DASP, which is decriminalization as prevention. So not only is that the decriminalization of sex work, because of how we see it sort of impacts how the sex worker community can then engage with care, but also the decriminalization of drugs, because we know also the impact on how people are able to then deal with their situation with less stigma and be able to again access care in different sort of ways. But also looking at how HIV laws are addressed in the country. So again, this decriminalization as a form of prevention is one of those conversations that's beyond, it's beyond the sort of clinical main capture. I think it's one that we need to start having more seriously as a conversation.
Thank you. Winnie?
I think for me, I have to go with treatment is prevention, and being undetectable equals not transmitting HIV. As a person living with HIV for 34 years now, I really didn't think that that would happen in my lifetime. And I think that's really incredible. But with that, I think we can't really take one thing on its own. I really want to give a shout out for social support. Social support is incredibly important. So not just the treatment on its own, but the social support that goes with it.
Absolutely, yes. I agree absolutely with everything that you've all said. But if we can actually start off now by talking about oral PrEP, so taking PrEP as tablets. Marta, could you tell us how that actually works?
Of course. So if you take antiretrovirals, we know that at the moment the most common PrEP are tenofovir, disoproxil fumarate, TDF, and FTC in one pill. We call it Truvada. It's not Truvada, but we know what we mean. So by taking that drug, you have the drug in the cells at the level where HIV can be transmitted, at the level where HIV would enter people's cells and blood. So having the drugs there block HIV progression into our body. So this is, mucosal tissues, rectal, vaginal, cervical. So it's full of drugs, and the drugs block the replication very, very early on, and so it just doesn't happen. There's no further replication beyond that barrier that is created by the presence of the drug there. It's really fascinating.
That's incredible. And is there a difference in the way that men and women, and also trans men and women, can take PrEP?
Well, it's a very good question. We don't have the perfect answer to that question. There are few research gaps because not every single person has been studied in terms of how long do you need to be on the drugs to be protected. I think that's still a research gap where we see differences between men and women. In terms of taking PrEP regularly, everybody's protected, at least after a week. I think it's the event-based PrEP that is associated to some research gaps. So I can't answer the questions on whether event-based is 100% protective for everybody, because it hasn't been studied.
Thank you.
That's a limitation.
And what do you think, Gus?
About event-based PrEP specifically, I've seen enough studies to show that people do use it appropriately. In other words, they do take it when they're at risk. There was a great study from Amsterdam, which was quite a complicated study, but it showed there's a really strong correlation between when people thought they were at risk and when they took the PrEP. That's among, I should say, well-informed gay men. So I think I like event-based PrEP because I think it's much more to like people's normal sort of sexual behaviour. You don't have sex every night, and perhaps unless you're a sex worker or something like that. But I mean, especially if you're someone like, for instance, who has a partner who's a migrant worker or something like that. You may see them once every month or 3 months or something like that. That's when that sort of, that's not even event-based PrEP, that's more what I would call intermittent PrEP, is something that may be really of great use to people.
Right, okay. And obviously we know PrEP works, but despite it being available to women at risk of HIV, uptake is low. Why do you think that is? If I ask Winnie and Chamut.
I will try and answer it and see if anybody else has it. I think it depends also, who you ask. But I think right from the get-go, there was a way that PrEP was framed when it was on the market. And I think that's where we got it wrong. And from that time on, there's a lack of awareness among heterosexual communities, among women, because it was framed as something that would be really useful for gay men. And I think there was something that was missed there, and we should learn from that and frame things well from the very beginning. Up to now, there's still a lack of information, especially where women are concerned. And that's really quite scary because women need to be, to protect themselves. And this is a really good tool as an individual to protect oneself. So we really need to work on raising more awareness in a way that people can actually engage with this information. One of those ways would be training community champions to be able to work within the communities. They have to be paid well in order to do this work well. And that's part of why I'm creating the Black Health Activists, Mentoring and Empowerment Network.
Fantastic, thank you. And what do you think?
Well, I would echo everything that Winnie has said. And I think one of the reasons why I mentioned equity from the beginning is because I think we need to do more in having an equity-based approach from the very beginning when we're setting our research objectives, because PrEP is a really good example where that was not considered, because on the tin it looks, PrEP, if you look at it, it's effective and it was shown to have efficacy universally in a way, although it's different, as you were saying, how it works exactly between men and women. But that is not, at least in the UK, what informed the drive or the push. It was sort of framed as a pill to prevent HIV transmission among gay men from a very early start. And there were not really parallel efforts to, what about other communities? At the time we knew that Black African heterosexual men and women were also disproportionately affected by HIV and had higher rates and higher incidence than the other populations. But there was no real effort or concern, or no one was blowing the whistle and saying, or there were some voices, but not loud enough to make a difference. And so I think now we're asking a question of access. Why are Black people not taking up PrEP, or why are women not taking up PrEP? But there's a question we need to ask before is, how have we let them know about PrEP? Do they know about PrEP? And I think the answer to that is really no. A lot of gay men know about PrEP, almost universally, but hardly any women or Black people, heterosexual Black African people know about PrEP, even if they could benefit from it. So I think we need to address that precursor and look at where people access trusted sources of information and look at an offer, because I think what we tend to hear is that, well, people are asked, if I'm asked to provide PrEP, I will if someone is eligible. But people from these communities may be expecting an offer, and if they are offered it, they may take it up. So do we need to have more of a conversation about switching it, where we're more actively advocating for people to have that knowledge and know that they can access it from places that are acceptable to them, not just in sexual health clinics?
Yeah, I think that's a really good point. And do people think that if PrEP was available, for instance, at chemists or GPs, do you think that uptake would be greater?
I have something I call the pharma counter test, which is my idea of like whether something is a prevention method that really has legs, as it were, which is, can you imagine this being sold at some point in the future, not necessarily now, over a pharmacist's counter without a prescription, like a condom could be. And if you can imagine that happening, then I think it's got a future. It may be difficult to imagine that as with an injection, but actually we've got newer things coming along that in the long distance may be available like that.
Very important because it would reduce stigma and the need for disclosing that you take PrEP if you don't want to disclose you take PrEP. So I think that would really promote that and help with access. Again, I mean, I think there are enough data to show that it's well tolerated, it's safe. So I, for example, wouldn't be against something like this if the information, associated or enclosed to the PrEP sold over the counter about where to get advice was very clear, for example.
Yeah, thank you. And yes.
So my feelings on it are, it would be great if it was in pharmacies, but I think some of the groundwork that needs to happen, particularly looking at the sex worker community again, just because that's where I'm representing today, I think there needs to be conversations where people in healthcare feel like they can facilitate levels of control in the sex worker community. So for example, if it comes to a sex worker negotiating with a client, what their boundaries are, if there is something that means the sex worker feels that they can be on PrEP without that somehow adding to the feeling that somehow the client will expect condomless sex, then that's the type of social dynamic that I think actually things like the NHS or healthcare organisations can get involved with without being dragged into this conversation of somehow enabling people to sex work. The harm reduction of saying, what tools do they need? Do sex workers need online profiles where they send to a client, the buttons get pressed, and something as simple as that, where they're saying, just because I'm on PrEP doesn't mean you get to make any extra choices.
That's a very good point. And how have you been sharing messages about PrEP, Jason?
So I often I've been on PrEP since around late 2015. And a lot of my clients I would speak to and I would explain about PrEP, but also in the porn industry I would as well with people that I would work with. And then eventually we formed a pledge, I'm wearing a t-shirt of today. Many organisations got involved and helped create it. And it's about being comfortable working with performers who are living with HIV. And in that resource, it also explains quite a lot about PrEP and starts to unpack how often people have the sort of fear around working with someone who's living with HIV, but that's so backwards when they've misunderstood things like window periods regarding how they test, and how much more of that sort of extra concern could actually go on to people who identify as being HIV negative, because there's very little certainty there when it comes to that window period time.
Yeah, fantastic. Getting a lot of questions from people about injectable PrEP. Marta, can you say what that actually is?
Of course. So we have a drug today that is called cabotegravir, that is an integrase inhibitor. It is also a drug that is used for treatment that has been approved as PrEP, and it is administered intramuscularly every other month and is able to prevent HIV acquisition. Actually, interestingly, in the clinical trials that compared the injectable cabotegravir to the oral PrEP, the injectable cabotegravir did better than the oral PrEP. Now, whether it is because it is a better drug or whether it is because of how it's administered, it's much easier to forget a pill, isn't it, every day, if versus an injection that you have your appointment on your phone and you show up at a clinic to get your injection. So we are not 100% clear, but it's working really well. And again, I think it could help people to stay adherent to PrEP.
Yeah, absolutely. And Gus, what's the global availability? Well, every country.
Yeah, I mean, the answer is not nearly enough. I want to add a little bit to what Marta said, which is when it was originally trialled as treatment, it was cabotegravir plus another injectable drug, rilpivirine, and that works kind of, or in the scientific trials, it worked about as well as standard oral treatment, but probably better for people who might have adherence difficulties. That's why it's great. In the prevention trials, it was spectacularly better. In the trial where it was given to gay men and transgender women, it stopped 2/3 more infections than oral PrEP did, which is something we're thinking about. So if we're being conservative about the efficacy of oral PrEP in gay men and trans women, let's call that 75%. 66% better than that, you come out with something that's more than 90% effective in trials of people who might be forgetting it and not turning up for their appointments. Right, it's not available in Europe at the moment. The drug company that make it have not actually even applied to the European Medicines Agency to make it available. Last time I heard that's because they said there wasn't enough demand in Europe. It has been licensed in America, and I do know a few people who are using it, but not many. There is a big drive because I think the company realized the pressure to make it available in lower income countries, and they have made an agreement with 5 companies for it to be produced for low income countries at a low price by generic companies, and that is great news, but it's not yet. It'll be starting to become generally available sometime next year. And I think what's really important about injectable PrEP is exactly what Winnie in particular was saying, and you, Sham, was that it gives us a chance to reset the image of PrEP, because it's going to start feeling a bit like taking a vaccine. Not every 2 months, perhaps, but there are other things coming down the pipeline, which you might be able to take less often than that. So let's start calling it something different. And also, there is a history with women in particular of injectable medications already. There are already injectable contraceptives. There are injectable hormones for transgender people. Perhaps a less good example, but there are injectable antipsychotics for people with mental health issues, which probably save lives. So I think we need to reset the image of PrEP and make it something that we imagine is going to be useful to a much wider range of people. Let's call it something like your PrEP shot or something like that. We can't call it a vaccine because it's not, but it might start to feel like something a bit similar.
What do you think, Winnie?
However, if we don't continue to raise awareness among the communities, especially the, what do they call us now? Racially minoritized communities, Black African, Black Caribbean, and brown communities in the UK. But of course, elsewhere in the world, we really need to raise awareness at how PrEP works, just so people are aware that it's available. Because there's a lot of stuff that is, available, but people are not accessing it because they are not aware. So and otherwise we are going to leave people behind. To quote.
It's very important what Gus said and you added. I think the name seems like a detail, but actually it's really important. You can't call it a vaccine, but you can call it something, the vaccine like, the prevention tool, or something positive associated to it to reframe PrEP, because it's really, really important, isn't it?
Yeah, what do you think?
Yeah, I think I agree. And I think, but it's also a bit of, it's like a complex social issue as well, because when you're asking, like, especially from a woman's perspective, let's say they're in a relationship which may on their side be one partner, but their partner may be having other partners. And that's the sort of person you'd say, you may be a good candidate for PrEP. But then they will be asking themselves, well, what does that mean? What are the implications for my relationship? Does that mean I don't trust that person? And so sometimes there are those sort of more complex discussions to be had. But it's, as Winnie says, if you don't know that PrEP even exists, you can't be in a position to use that. And we've spoken about women and racially minoritized communities. And what we also see now is while overall gay and bisexual men do have the most take-up, actually racially minoritized gay men have a lot less take-up as well. So we see like these issues kind of being echoed around equity. And so I think the awareness bit can't be overstated enough.
Absolutely. And do you think that there could be stigma for some people in terms of being seen to be taking oral PrEP? Would injectable PrEP really help with that?
I'm going to jump in with this one because in the sex worker community, HIV has had this, I wouldn't say unique perspective, but it's often looked at as a facet of sex worker stigma. People looking at sex workers and saying, this is, all of the classic stigmatizing sentences through that sort of lens. And so in the organising spaces for sex workers, the reactions have been very mixed. It's been quite difficult to get conversations out about PrEP because, like with what you were saying, what does that say about us? How are people treating us? So all of that is what kind of needs to be unpacked. And it's one of the reasons why I talk about decriminalization, so that people feel like actually these conversations can happen without as much threat happening at the same time.
And do you think that there's sufficient funding for sex worker programs in terms of these types of initiatives and raising awareness?
It's interesting you say that because, frustratingly, sex workers didn't get COVID vaccination access early, and we didn't really get support for most of us when we didn't have bank accounts or many weren't paying taxes, so they weren't eligible for different types of support. Likely, it's the same. We didn't get early access for monkeypox vaccination, and we don't really get access to things like the HIV PCR test, which would mean in the porn industry, someone who's living with HIV could take that test, show that they're safe to work in a way that means they wouldn't be discriminated against in the industry, because it would also mean they could potentially be HIV negative and pass that test. We don't get these different types of parts of care because they cost, and our care is sort of divvied up into what the general public get as a component of the general public. And if it's not something the general public are getting, sex workers aren't getting it. There's no space for innovative care for sex workers specifically without it being targeted and removed by people who are against sex worker rights. Even though it's harm reduction, it still gets targeted. And that's what needs to change.
Yeah, that's a very important point. Another exciting new form of HIV prevention is the vaginal ring. Marta, I keep coming to you about how things work, but how does that work?
Absolutely. So that's a ring that you place in the vagina that releases the drug locally. So in terms of how it works, it's very similar to what we discussed earlier. You have the drug where HIV would make its way through the tissue, the skin and the mucosa, and it just blocks the replication. The history of the development of the rings has not been a very happy one. I think that it's such a different way of preventing transmission that it should have been studied maybe in a different way. What I think it's really important is to have a choice. PrEP shouldn't be one thing, and that brings a choice. I am sure some people would prefer a ring to a pill or an injection to a ring. limiting choice, I think it limits the possibility of increasing awareness, the choices for people. It limits the possibility of lowering the transmission, preventing transmission. In fact, the FDA in the United States reviewed the data on how useful the ring can be and hasn't approved it. Following many years of trying to develop it and many studies, and maybe because the clinical trials don't seem to be very promising. However, again, it's such a different tool that I wonder whether it was studied in the way that it should have been studied.
Yeah, no, absolutely. And what do you think, Gus?
In Europe, the history of it is even stranger because the European Medicines Agency, under one of their clauses, is able to approve medicines for low-income countries, which it doesn't necessarily approve for high-income countries. So it approved the vaginal ring for Africa, but not for Europe, which is a very strange decision, I think. Probably because I agree with Marta, it was unfortunate in a way the way it was studied, because in clinical trials it didn't come out as fantastically effective, stopping about 1 in 3 infections, something like that, okay. But later trials in which women were given a free choice as to whether they use it or not, it was more effective, something like 60% effective, I think, in the highest one I've seen. So there you're getting much more to a useful level of effectiveness, right? Why might a woman prefer a vaginal ring over an injection or a pill? Because, especially if she's worried about side effects, I think. And when they ask people about why they don't take PrEP, 3 big reasons stand out. One is, I don't think I'm at risk, which I think is often the form of denial, but not always, but often because they may have partners who are lying to them or whatever. Another is, I'm afraid of the side effects. And the third is stigma. Somebody might see the pills and think I have HIV or that I'm promiscuous. But the side effects do pop up consistently in studies of why people don't take PrEP. And I think that's because people have a sort of folk memory of the old days when HIV drugs were pretty rough and did have bad side effects. Well, they really don't now. But people still think, or worry that they will. And so I think one of the things about a vaginal ring, you can take it out if you're not comfortable with it. Okay, that may be not very good for prevention terms, but if you're worried about side effects, then maybe you can fit your lifestyle around it and still sort of reduce your anxiety.
Sure.
Well, if we are talking about the vaginal ring that's preventing HIV in Africa, and I think a couple of countries it has been approved. I read recently that I think South Africa has put its rollout on hold because it's still examining, how effective it is. But we know now that many of the new infections are among young women, young girls and women, maybe between ages of 15 and 24. There are a lot of issues around that. There are challenges in how they access care and how they are looked at by healthcare workers. There's some of the things that I encounter when I talk to organizations or to young people, they say the challenge. Healthcare workers are very judgmental. Healthcare workers might know their parents. And young people have to be escorted to do that, to get that. However, if we are seeing new infections, and this is a personal issue for me, if we are seeing new infections among young people, where are those infections coming from? And if we are not working parallel to have opportunities to make sure that wherever those infections are coming from, those people are also getting an opportunity to test, then we are only looking at one part of the problem.
Absolutely. And I wanted to move on to testing for people to be able to benefit, certainly in terms of treatment as prevention. They need to know their HIV status. Jason, what do you think are some of the barriers to people testing for HIV?
So I'm going to pick up a little bit on Gus pointed three main reasons why people aren't doing certain things. And it's the same sort of reasons for why people aren't testing. Of that first one, which comes to them not thinking that they're at a risk, if you look at, again, their awareness of what a window period is and how much they critically apply that knowledge, are they doing something where they are having a test and they're feeling like that is somehow like an all clear card, and then they're going on with life and then taking another test and saying that's an all clear card? Or are they thinking about that test has that duration where it may not actually show those infections I've maybe acquired during that time, and I need to look back to the beginning of the window period as my time for when it reflects? If they're not applying that information, then again people will be thinking my partners are HIV negative, so that is a mechanism that keeps me safe, when actually that is built on a false sense of security with unknowns that they cannot know. So that conversation needs to happen as far as an educational thing with how testing is being provided.
Absolutely. And Cham, I mean, what do we need to do to encourage more people to test for HIV?
Yeah, I think that's a really good framing. Like, a lot of the people who we want to test don't think that testing is relevant for them. They don't think they're at risk. So how are you trying to get someone who doesn't think this is something for me to then go out and get a test? So I think, so for the national program, we work on campaigns. This is one of the biggest things that we do through like National HIV Testing Week and more. And one of the things we always want to focus on is having a very relevant and clear and simple to understand message. The messaging we use is really critical, because if someone can't relate to that message, then they can't take up an action. So I think the relevance has to be there. And I think being targeted, it's still a really effective approach. The epidemic has really been changing really rapidly over time. And so we see the numbers who are undiagnosed getting smaller, but more diverse. So how do you have targeted messaging? There's still a space when we look at certain groups, like among gay and bisexual men or Black African heterosexuals or migrants. But there are a lot of other people who were like born here, white heterosexual people who are also being diagnosed at really significant proportions. How do you make relevant messaging for them? It's a really complex question. But we just need to make people who are, may not have that exposure, like migrants who are new to the country, who may not know that testing is free, who may not know where to get testing, who may not know about digital testing options. So people need to know what options are available to them. And when we're talking about setting up new services or making changes to existing ones, we need to ask, is this something that's going to work for people's needs? Are the hours going to be accessible? Is it going to be in a location they can get to? If they're in a remote or rural area, are there online testing options? If they're worried about privacy and confidentiality where they're living or working or whoever they're with, can they just get something that works for them? I think those are probably the biggest issues. I think if we could tick off, I think it would go really far, although, it's not the end of the list.
No, absolutely. And Winnie, how important is representation in terms of testing campaigns? I was thrilled that you took part in NAM's testing campaign with African Advocacy Foundation, encouraging people to test for HIV, but actually showing people from Black communities who are living with HIV talking about why it's important.
I really think it's important that people are represented, because I think part of the challenge is that some people don't see themselves in different spaces and therefore think that maybe that is not for me. Maybe that is for somebody else. But if people are represented, it's really important, so that they hear the message that, this affects everyone, whoever you are, but it can be, look how representative this panel is. I'm happy to say that those are the kinds of panels we should see. But also for me, it's really about what have we learned through these 40 years of HIV and passing that information on into different areas of work where there are health inequalities among different communities, and using that, learning to make sure that people, get the information that they need. One last thing I want to be able to make, and I know this requires resources, to make sure that there are services, for instance, if people go into emergency, for A&E, where people, are offered this, and then they can just opt out.
Yes, and
Right.
and it's fantastic that we actually have that in London now. How significant do you think that opt-out testing is going to be?
So we are seeing really important results with that. So at Chelsea Westminster we have different clinics, different A&E, and in Northwest London where I work, we are really making sure that HIV test is implemented in all the region, and the results are very important, and also they increase awareness. They increase awareness in a way that is more equitable than just targeting certain people that would fear being targeted. So I think it's very, very important. It is working well, I would like to say.
That's good.
Yes, and this is both important from a public health point of view, but also from an individualized person's health point of view. You're changing their world and their lives, so it's working well. I think it's a great project.
Fantastic. And I wanted to move on to treatment as prevention. Gus, how important is it for you as a person living with HIV, knowing that you can't pass HIV on to sexual partners?
I mean, I think I said in my intro that I kind of knew this from quite early on, because I think the first study that showed that if people were adherent and they got an undetectable viral load, then essentially they didn't pass on HIV, dates from something like 1999. But it took a long time for people to accept that. In a way, treatment as prevention is simple. Treatment is prevention. In other words, if you get treatment right, then for positive people, you will get prevention right too, because if treatment works for them, they'll become undetectable and they won't be infectious, and it's as simple as that. So everything we've been talking about, access, making sure, equity, reducing stigma, maybe things like injectables, all contribute to prevention. But it was the way that was framed that had to be changed, because it used to, I came across very well-intentioned sort of HIV prevention experts who say you can't tell positive people that because they'll immediately abandon using condoms. And I might as well tell this story. I've told it before. It was before one of the CROI conferences, I think in 2017. This American guy called Bruce contacted me out of the blue and said, look, I've recently been diagnosed positive, right? And I was outraged because the doctor said, oh, well, if you become undetectable, then you won't be infectious anymore. And nobody told me this. And I'm outraged this is not being told to positive people. I want to get your opinion on how we might do a campaign. So I arranged to meet him outside the CROI conference in Boston at a coffee bar, and he said, what do you think we should call this? Because we can't call it treatment as prevention. I said, well, if people are sort of undetectable, then they're uninfectious, aren't they? You equals you. I literally wrote it on a napkin. What do you think of that? Well, I don't have the marketing genius of Bruce Richmond, whose job before this was in arranging the public profiles of celebrities. He knows how to make this stuff work, and he basically ran with it, and it became you equals you. And I think it's also a really important contributor to reducing HIV stigma and criminalisation, because if people know that they cannot pass it on, then firstly, it's a contributor to them it enables them to not regard themselves as a danger, and not regard their HIV as something to be ashamed of, and also it can actually change legal decisions around criminalisation. So it's really, really important, and it's a major contributor to reducing HIV infections.
Yeah, absolutely. And Winnie, what role do you think people with HIV play in HIV prevention?
Oh my God, we play a huge role. Having been out there for a long time, and you know, this is not a competition, but I remember being on the cover of Positive Nation as the first black woman on Positive Nation.
She got there first.
First pregnant woman.
Yeah, but you know, it is really important for, you know, for us to be seen as living well with HIV, as passing on this knowledge to, you know, to people in our communities, as you know, and saying that you can avoid getting HIV, but we need to make sure that people update their information, because what we are fighting at the moment is people are stuck with information from the 1980s, and their information in their head hasn't progressed to, you know, 2022. You know, they just almost, they don't want to hear it. There are people who don't want to accept the science, and those are a small minority. But we really need to continue to make sure people know the updated information about it.
Absolutely, yes.
So, in the porn world, in the porn industry, we've seen a real condensing of this happening, where there was really strong retaliations when people started saying, porn performers who are undetectable, safe to work, and you've got these really strong opinions. And to me, it's a pipe dream, but from the conversations that we said earlier, in the porn industry, if there was PCR testing, then obviously if someone's undetectable, it can, you know, the test will have a non-reactive result, and if they're negative, they have a non-reactive result. It costs quite a lot, but how amazing is that one test could say this, you know, this person is safe, or whatever language is identified as non-stigmatizing. Wouldn't that be great if wider society could use a model like that in some ways? So it could just say whether you're undetectable, whether you're negative, and just bypass so much of that stigma.
Absolutely, such a good point. And we've only got 8 more minutes, and there's a few. Got some questions coming in from the audience. One question is: are condoms still relevant?
Yes.
Quick answer.
I know a lot of people, you know, especially now we're in the era of PrEP, and I think PrEP has been a game changer, but condoms is still relevant. There are still people who are really comfortable with using it. You know, you can just go to any drugstore, you can go online, you can buy it, you can put it in your pocket or in your bag. You know, it's quick and easy, and it works, and it's effective. So I think we should always have a place for it, for people to be able to have that as an option. We can't forget about it, I don't think.
Yeah, no,
it's not the only thing.
Yeah, choice is important.
Yeah.
And Marta, how does treatment prevent vertical transmission from a mother to a child?
Yes, that has been another revolutionary discovery in the field when, again, you know, having the drugs around creates a barrier so that the virus doesn't replicate, doesn't go around, doesn't get through the placenta, and so babies are born without HIV. I hope you would agree with me that actually that was the first sign of PrEP, the first time. So from that, we started to think, but then antiretrovirals prevent HIV from going around, from transpasses certain areas that need to be transpassed for the infection to happen. So it's been incredible.
It's so important.
So important.
I mean, but we have to remember that there still are so many people around the world that do not have access to treatment. So it's so important just that we have equitable access to treatment and to testing, and also for viral load testing. around the world. Another question, is PEP still relevant? What do you think, Marta?
I think PEP is very relevant. As Gus was saying, we are very excited about injectable PrEP, but we don't have it. So PrEP is pills, and people get tired of taking pills. So we see phases where there is an increased PEP uptake because people may get tired of getting pills, they forget, or lifestyle changes. So PEP is definitely still relevant. Very important for us to also keep studying it, making sure we offer the best PEP we can. It's not studied enough. I think there's so much more to learn. Do we really need to give it for that long? Do we really need to give 3 drugs? There is a lot to learn, and we don't have enough interest in studying it, unfortunately.
Just on the PEP, I think as well, now the conversations move to PrEP. I think it's actually hard for people to get PEP, unless they know about it. So I think we also need to make sure people still know that PEP is an option post as well.
That's a very good point. And I've got a question here. Are there any side effects from taking PrEP? Gus, would you like to answer that very quickly?
Yes, very rapidly. The 2 drugs that we currently use most often for PrEP, one probably has very serious side effects, another tenofovir. It sometimes affects your kidneys a bit. Certainly with older people, I would have a regular check of kidney function if I was taking PrEP. Also, it may sometimes interfere with bone mineral density. That's more a consideration for younger people. As long as those 2 things are monitored, and they always are if you get your PrEP from a clinic, or should be, then in terms of more acute side effects, you may feel, get a bit of a headache, feel a little bit nauseous first few doses. Other than that, generally not.
Okay. And final question from the audience. Are we any closer to finding a vaccine against HIV, Marta?
We're trying very hard still. There are many clinical trials that are happening, some at Chelsea Westminster, some all over London, in the UK, in the States. We're definitely not giving up. We're looking at alternatives, ways of preventing HIV transmissions. We'll get there.
Fantastic. And what's in the pipeline, Gus? What's coming up?
Well, there are other things. Probably the next drug that might come along that could be used as an injectable is a thing called Lena Capovir. Very interesting. They've just started a couple of big randomized studies of them. This would be a subcutaneous, a small injection, probably in your arm somewhere or something like that. A bit like the monkeypox vaccine, that would be able to be given once every 3 months, something like that. So we're moving a little closer to something might feel like a vaccine. There was a drug called islatravir that's on hold at the moment. We don't know if it's going to work or not, but that potentially could have been dosed once a year if done as an implant, which you can take out, but that may be some way further down the line. Lena Capovir, very excitingly, is also going to be the subject of only the second PrEP study conducted in injecting drug users. That's several years down the line, but we don't really know whether PrEP works for people who catch HIV through injection. So that will be very exciting if they manage to find out an answer for that.
Okay, fantastic. And yes.
I find this really, really exciting because I'm someone who has epilepsy, and I take regular medication for my epilepsy, as well as being on PrEP for a long time. And I think sometimes people overlook the fact that people may have concerns about cumulative impacts on their body, even if they're not having kidney impact straight away or anything like that. And I know it's incredibly well tolerated, but when I particularly talk with female sex workers, they're quite excited by the idea of injections because it's not passing through the same body, it's not entering the body in the same way. So there's a lot of exciting bits of future there, particularly as sex workers are very neurodiverse, often there's a lot of disability in the community as well. So
fantastic. And we've got 1 more minute. So one quick fire question to all of us. If you could say very quickly one thing that needs to happen now to improve HIV prevention, if we'll go around, starting with you, Gus.
Oh, it's on the top of my head, so get the injectables licensed.
For me, it would be to consider people who've been lost to care and include them as part of the conversation.
Fantastic.
Awareness.
Awareness.
I
Jason?
would say peer leadership. Get the communities involved, employed at the heart of those pieces of work, and keep their intersectional views.
Wonderful. And finally,
We are
Winnie.
talking about HIV infection here. People need to also protect themselves against other sexually transmitted infections.
Absolutely. Well, oh my goodness, we are actually out of time. I'd like to thank you all so much for coming on. I'd like to thank the absolutely brilliant, disruptive live team. Woohoo! Thank you so much for having us in the studio, and thank you all so much for joining us today. Thanks. Bye.